I can take this one. As it's coming into focus, I can just see tons and tons of inflammation around what kind of appear to be three, four. They're still out of
Yeah,
focus.
I know.
Sinus
There we go.
tract.
Yeah, okay, good.
Um, and uh, it looks like it is involving most of the dermis.
Yeah,
And
and
this is a
even
big.
even down to the
This is
sub-Q.
almost like an excision.
Yeah,
Yep, all the way down to the fat, and that track keeps going down deep. So I'm still struggling to see cell types, but it does look like a dirty inflammatory mix.
yeah.
Newts.
Neutrophils, yeah. A little of everything, right? Newts, lymphs, plasma cells, often EOs, red cell extravasation, all of it. Throw it all together. It's the kitchen
Yeah.
sink.
So one thing I always wonder is, are plasma cells more disease specific or site specific? Because a lot of diseases we see with plasma cells are specific for sites.
It's a great point.
Getting to the diagnosis at hand, this is hidradenitis suppurativa
Yeah,
or some kind of follicular triad kind of disease.
yeah, exactly. So the you can learn a couple diseases for the price of one here. This is like a real classic example of hidradenitis suppurativa, HS, which is usually in the groin or the axilla or under the breast fold sites, and has multiple draining sinus tracts. Is really morbid, terrible disease, as you guys all know. What you see microscopically can vary greatly from case to case, and the clinical is dramatically important. If you just show me this and said rule out cyst, I'd say cool, inflamed ruptured cyst, no problem. If you told me I want hidradenitis suppurativa, I'd say consistent with hidradenitis suppurativa. If you told me this was a draining tract in the superior gluteal cleft, and you wanted pilonidal sinus or cyst or tract or pilonidal disease, as I call it, I would say consistent with pilonidal disease. So all this pattern can fit with ruptured cyst, hidradenitis, pilonidal. All of those can show an overlapping and sometimes identical mixture of features. And those features include actual cyst wall, often inflamed, often edematous and spongy, plus minus rupture, plus minus keratin debris, often with keratin granulomas, often with really brisk inflammation that's rich in lymphs and plasma cells. You may or may not have neutrophil abscesses. You often have a lot of granulation tissue with edema. Sometimes you'll just see granulation tissue that has pseudocystic edema in the middle with no cyst lining at all. Sometimes it'll just be mostly scarred down with features of like a burnt out ruptured cyst. Any of those combo of features in the clinical setting of hidradenitis, I will say is consistent with hidradenitis. Or if you wanted it just a solitary lesion and it's only a ruptured cyst clinically, then it's fine for a ruptured cyst. And the same thing, pilonidal, which will classically have a mixture of these things plus naked hair shafts, it over half the cases I see don't have naked hair shafts. So they may have any of this combo. So all of those things could be hidradenitis or pilonidal or ruptured cyst. All right, good job.